So thank you very much. Thanks, Shanogi, for supporting this symposium. My talk will be more clinical oriented, and then I'll leave Dr. Raul Andino to speak more on the molecular mechanisms of virus persistence. So we are now more than 3 years into the COVID pandemic. Again, these are my disclaimers. And I already showed these slides before. As I said before, we were hoping that these post-viral syndromes that Dr. Gandhi explained yesterday excellently, these would go away. That was my first hope. But Dr. Lourdes Mateo, who's sitting back there, she already told me, no, this is not true. This is staying. This is a real disease. I was skeptical at the beginning, but she convinced me. Also, the evidence convinced me that it's not true. That this is a problem. This is a big elephant in the room. This is something that's here. Policy makers and public health, I would say ministers or economy responsibles in Europe don't want to, are so far overall are looking somewhere else, but this is something that it's not leaving. And my talk will be about what should be, I think it's our responsibility to think about how can we end this long COVID pandemic, not only describing it, but also thinking ahead and say, okay, this is here. It is a very complex issue. It's not easy. We're not going to hit the home run just tomorrow, but we need to start thinking about it. And the model, and this is the model I will follow during my presentation. So we know that there's a lot of acute COVID-19. We have no, I would say, milder variants in comparison with the previous ones. But of course, if the vaccination status is also playing a big role, it has been said that Omicron as a virus is as pathogenic as the initial Wuhan strain. So I don't know what would have happened if the first virus that we saw as human beings was Omicron. Probably it would have been a disaster, just as with the previous viruses. But the good thing is that, okay, there's less people nowadays who develops long COVID, but there's still a significant amount of people who end up developing long COVID. And because this virus is so transmissible, at the end, the numbers of people with long COVID, even if it's 5% or even 3% or 2%, is already too much. So we have a big number of people with long COVID in Europe and in the world, everywhere in the world. And of course, some of them recover. Unfortunately, it is a minority. And it depends on how we define our cohorts. We might have different numbers, but also a lot of them persist. And what is important also is that now we are having reinfections, and also I think that reinfections are playing an important role in maintaining this system of communicating via with a lot of long COVID. So if we want to end long COVID, first of all, we want to prevent new long COVID from happening. And I will discuss a little bit what we know so far, but also we need to start thinking about treatments. It is very important to characterize our cohorts. Each cohort has a slightly different characteristics. This explains the differences in prevalence and in incidence to a large extent, but what we really need to start thinking is what can we do to increase whatever number of patients recover and also reduce persistence. If we start with the second part, what have we learned so far? So one of the main first studies is the post-COVID study. This study was performed in hospitalized patients. It was published in Lancet Respiratory Medicine. And what you can see here is that at 5 months, already 25% of, this was essentially a hospitalized cohort, already 25% had recovered, 20% were not sure, and 50% felt that that did not have fully recovered from COVID-19. When they looked at what happened 1 year following the acute COVID infection, there was, up to 30% of patients who had fully recovered, 22.4% who still didn't know, but still 50% of patients who had recovered. And what is interesting is that there was a little difference from the first time point at 5 months and 1 year. And the main factors related with recovery were female sex, invasive mechanical ventilation, and obesity. Also, as was mentioned before, Scotland is and the UK have wonderful systems to look at outcomes at a population level, and what they observed in these also very large cohort of confirmed SARS-CoV-2 infections, and compared with people who were never infected, they found that only 6% of patients had not recovered, and up to 42% only partially recovered 18 months after following the acute infection. Here you can see factors related with lack of recovery. I will then dig a little bit more. I will use my also to dig a little bit deeper on a cohort that we published in, the data from our cohort in Barcelona, in Hospital Germans Trias, which is led by Lourdes Mateu and Marta Massanella, and also the whole team, where we let me start by saying that this is a biased cohort because this is a hospitalized, a hospital cohort of ambulatory patients. So because our healthcare system in Spain, like in many other places in Europe, it's so ill prepared to deal with long COVID patients. Of course, we always, and it's difficult for patients to reach us, we always have patients with more severe long COVID presentation. So this was, and Marta Massanella presented an update in the numbers yesterday. I will just stick to those published. So this is an observational prospective cohort study of COVID-19 survivors between May 2020 and February 2022. Essentially, almost all of our patients were not vaccinated when they were recruited, and this is another source of bias. So, and this was a pre-Omicron cohort. So it's the third source of, I would say, bias. So from this cohort called King cohort, we identified a number of patients who did not have persistent symptoms, but also up to 62% of our patients, 341, had fulfilled the criteria for post-COVID condition. Importantly, an advantage in comparison with the previous mentioned limitations is that Dr. Mateu's team performed a systematic collection of a comprehensive list of symptoms and functional scales. And this is an advantage relative to sometimes public cohorts because based on reporting. The reporting was done using in a specified way. In our cohort, the key baseline characteristics were that most patients, both in the PCC and the no PCC, were females. So actually in the PCC were more, almost 70% of our patients in the PCC group were females. It is interesting that they were less likely to have tertiary or higher educational studies. They were engaged in less likely to be engaged in regular physical activity, had a higher number of comorbidities, and less of them had been hospitalized. So it was the acute COVID-19 had been relatively mild, and almost all of them had been infected with ancestral variants. Essentially, the most prevalent symptoms in our PCC cohort were those that have been described elsewhere, no major differences. And here's a very nice graph done by Marta Massanella, clustering all these groups of symptoms. And the first issue that we wanted to ask was if there were determinants of onset. And what we observed is that there were a number of conditions like fibromyalgia, headache, insomnia, and autoimmune disease, for example, example, that were significantly associated with increased risk of developing long COVID. Actually, solid organ transplantation, male sex, immunosuppressive therapy were on the other end. We don't have enough power to provide definitive conclusions, but this is another area of interest, whether immunosuppressive therapy or maybe immune modulators could be preventing the PCC, but it's open for discussion, and you guys might have more data on that. But also the determinants, the presenting symptoms were also very important. So patients who presented with dysphonia, tinnitus, visual alterations, insomnia, and also neurocognitive complaints, neurosensitive alterations, tachycardia, dizziness, all these patients were clearly more likely to end up being in the PCC group, whereas things like fever or weight loss were not really discriminating the risk of PCC. Then we constructed two models, multivariate models to see which could be these determinants of onset. The model on the left-hand side only includes pre-existing conditions. It had a pretty nice fit. It always has 75% area under the curve, but the model on the right, which combined pre-existing conditions and presenting symptoms, had a much better fit. Of course, one of the key aspects is that we need an external validation of these. This is what we found in our group, but it would be very nice to see how this performs in your cohorts, so you can easily take these data and see whether we are right or wrong, and I think that would be very important. What we saw here was that actually male sex and tertiary studies, for example, were associated with a reduced risk of developing long COVID, and then a number of symptoms at presentation that are shown here below were associated with increased presentation of long COVID. Again, we evaluated symptom clusters, and essentially we replicated what the RECOVER group had done. Actually, when we saw the presentation from the paper from the RECOVER, we said, "Oh no, they scooped us," and actually, but that's very nice. What we see, however, is that, and this is something also for discussion, one of the aims of these clusters is to identify patients that can be separated and that can be mutually exclusive. That would be what would lead us clinically to maybe targeting specific interventions on the different clusters. Honestly, we don't see that. What we see, and of course it's a small study, what we see is that these clusters are actually separated because of the addition of additional symptoms. For example, everyone has fatigue, cluster B and C has neurocognitive alterations as well, and then of course cluster C is the one with more symptoms, cluster B has a little bit less, and cluster A would be the group of patients with relatively less symptomatic. Again, as I mentioned before, we could see, we were quite obsessed with finding organic evidence of lesions, because this is what our policymakers they dismiss sometimes. And as I said before, there were a group of, I would say women, because most of them were women with chest pain. And when we did adenosine stress MRIs, there was actually myocardial hypoperfusion in a significant number of them. Then we wanted to ask ourselves, okay, which are the factors related with recovery? Because what we want these patients is to recover. And the first finding was that only 7.6% of our cohort fully recovered over 2 years. One limitation of our study is that we don't have the gradation, so we were not. It is possible that there was another fraction of patients who had relative improvements. Here we are showing return to baseline, and baseline is before COVID status, but it was only a minority. And then because this was a small group, what we decided to do is a direct acyclic graph approach of the PCC resolution. And also what we have found here is, for example, there were factors like smell and taste or hyperexia, which are actually associated with an increased risk, an increased chance of recovery, whereas myalgia, dyspnea, tachycardia, neurocognitive disorders at at baseline, were actually highlighting which patients were not recovering. Importantly, almost all patients who recovered belong to the cluster A. So, and that also provides another clinical insight. So if you have patients with more symptoms, with a more severe disease, they are less likely to recover fully. I'm sorry because we missed, this is a river plot of what happened with vaccines, with vaccination dose. And of course, there's a huge controversy here about symptoms. I don't know what happened to my, here.
Okay.
And long COVID patients some long COVID patients are scared of becoming vaccinated again because there's a lot of fuss around saying, okay, vaccines could worsen our long COVID symptoms. Essentially, this is the first dose, second dose, and third dose. This is not a causal, it should not be interpreted causally, but essentially what we saw was that there was a decrease in vaccination as we went ahead, and we think that's not good. But essentially, most patients felt no changes when they were vaccinated, and I think it's also important to highlight that. Okay, in conclusions, there are pre-existing medical conditions are associated with a clinical presentation. This allows some early stratification of risk. There are subsyndromic clusters. This is concordant with recover, but what we see is additive severity of single multisystemic multifaceted post-viral syndrome, and recovery from PCC is rare. So healthcare systems must acknowledge PCC and be prepared. Additional one question is what happens with Omicron, and these data from Denmark. Even if Omicron is associated with less at risk of developing long COVID, what you see is that once you get Omicron, the disability scores remain the same, are similar. So less chances to have Omicron, but if you had Omicron and long COVID, the disability remains the same. So there's failure to improve in this cohort with different measures of asthenia, quality of life. So it's, we should not undermine, just say, okay, because you were infected with Omicron, the chances of developing long COVID are lower, but if you get long COVID, the evolution seems to be very similar. There's a very large population-based study in Zurich, and it's a complex slide, but what I want to show is that up to, in this very well-done study published in BMJ, up to 18% of patients following acute COVID develop long COVID, so it's a significant amount, but also the evolution was a little bit hectic, but a lot of them continued with having symptoms. Here you see the same data looking at different symptoms, and what you can see is also persistence even in this Zurich cohort. Looking, for example, at no recovery at 6 months, with problems with self-care, problems during usual activities, pain or discomfort, anxiety, depression, mobility problems, fatigue, dyspnea. So it doesn't seem to go away, not even in Zurich. And of course, this is leading to a lot of disability. And this is something that we need to bring back to our politicians and say, okay, we need to do more. So in terms of prevention, what can we do? So the first thing is also, there are four aspects that I think are important. First is vaccines. It was Dr. Gandhi mentioned that yesterday. The second one is understanding the role of variants, avoiding reinfections as well, and early antivirals. And I will go very quickly through, because there has been a lot of research, and what you can see here is that a complete vaccination schedule is actually reducing your chances of developing long COVID. So people must be vaccinated, and also we need to strengthen this message that even long COVID patients have to be vaccinated. This is a meta-analysis that has been accepted for publication in Lancet Respiratory Medicine, where I'm showing it with permission of the authors. And this is looking at 4 different primary care cohorts, 2 in the UK, 1 in Catalonia, and 1 in Estonia. This is done by Dr. Prieto Alhambra's group at Oxford, confirming that any vaccination is actually associated with reductions in the risk of long COVID. So what about variants? So you can see here, as was mentioned yesterday by Dr. Gandhi, that Omicron is actually associated with lower risk of developing long COVID. That does not mean, as I said before, if you're unfortunate, if you get long COVID, then the evolution, so far, we have not seen that the evolution of Omicron once you have long COVID is different from the previous one. The good news is that with Omicron, you get less long COVID. However, there are so many infections that then the absolute numbers might still be really worrying. And as was mentioned here, you can see the effect of, there's a combination effect with both vaccination and Omicron compared to Delta. So you can see a larger reduction when you look at all age groups in this large study published in Lancet, comes with Omicron, but also when vaccines have been given 3 to 6 months. So if your vaccination has been performed in the previous 3 months, there's already a reduction in the risk, but when you go beyond three months, the risk is higher. And these are the data separating people above and below 60 years old. So in other words, there's no evidence of heterogeneity. So this both vaccination in the context of Omicron works for the younger, but also at the older patients. What happens with reinfections then? And in these veteran affair, reinfections are a problem because in this Veterans Affair study, they are associated with increased risk of all-cause mortality, hospitalization, and at least one sequelae. You can see then that these effects last, and this is up to 180 days since infection. Of course, they decrease, but they remain at a certain level. And in also another paper that has been accepted in Nature, well, it's actually published in Nature Communications already by the group by Dr. Alhambra, which we helped. Reinfections in 2 different primary care cohorts were associated with increase in symptoms all over the place. So reinfections for long COVID are not good. So we should really avoid them. And what can we do to avoid them? So I will not touch into the masks and distancing. This is something that it's more complex, and we can, but it's also important to discuss, but at least we have some very early data on treating with early antivirals. For example, nirmatrelvir, ritonavir has been associated also with reductions in PCC. Here you also reductions in thrombotic diseases following acute infection. There's this amazing data from early metformin, the group by Bramante and colleagues, and it will be shown later during the presentation, where actually early metformin is associated with reduction of long COVID symptoms. And this is a very interesting, it has been shown, I've seen the presentations in the past, metformin might have some antiviral effects, but it might also have some other immunomodulatory effects. So I think this will be very interesting to understand. And also, of course, ensitrelvir in these data were presented at CROI. Ensitrelvir is also an antiviral done by Shinogi. In this case, there's a consistent reduction in a number of COVID-19 symptoms. It is true that many of these findings were not expected when the clinical trials were designed. But I think it's good enough, and they're important enough just to think about, prospectively incorporating long COVID outcomes, at least up to 3 months. And this is something that can be done. It's not impossible in all these new clinical trials targeting antiviral strategies or metformin as well. So in conclusion, I think I'm on time. Yes. So the first conclusion is that long COVID lasts for long, and in some cases for very long. So this is not going away. This creates high disability. The long-term duration, once you unfortunately have long COVID, does not seem to be affected by variants or vaccines as of today. Variants or vaccines are reducing your chances of developing long COVID, but if unfortunately you have long COVID, at least I've been unable to see a difference in the evolution by Omicron versus other variants. Improvement is possible, so I also want to bring a little bit of hope. Improvement is possible, but certainly is for the less severe cases. So we need to do more, and governments need to do more. There needs to be more funding because we have the urgent need for prevention tools to reduce new incident cases and worsening of symptoms. That includes vaccines. Long COVID, people with suffering long COVID must understand that vaccines are good for them, even though there is a small proportion of patients that might have a transient worsening, but vaccines are important. It is important to avoid reinfections. So and this is an opinion, in my opinion, long COVID patients should be considered a high-risk group, not necessarily for hospitalizations, but in terms of I think this should be a group of patients where the antivirals should be really targeted. And we certainly need to treat reinfections very quickly. This is not in the current guidelines, so this is up to discussion right now, but this is, I'm really giving you my opinion. And also the urgent need of treatments. Every cohort is different for treatments for established long COVID. So, and I would like to end again by acknowledging the very important role of patients. In our case is a group of COVID persistent. I think I come from the HIV world, and without patients and without patients pushing, it would have been impossible to make all the advances that we have observed. And unfortunately for patients are already carrying a high burden, and they probably have to carry the burden of pushing even further, which is bad for them because they are tired and they're, but it's not simply, governments don't simply work or start doing things because of science. And of course, I want to acknowledge Marta, who's the lead, Marta Massanella, who's the leader in the lab, so the lab studies, and Lourdes Mateo, who created this cohort and believed in long COVID since the first day, and also, of course, all the team, and finally, our collaborators at Oxford. Thank you very much.